review one. I just want to go over some of these concepts before you actually graduate. Are there any comments, questions, concerns that we need to go over before we start? We're good? Okay. So here's our patient, 24 years old. Came to the emergency department, sudden onset of chest pain and shortness of breath. So what history will you take? Cardiac and respiratory. All right, so let's talk about history before we talk about physical exam. What kind of questions are you asking this fellow? When did it start? He's going to tell you it's sudden. Is anything increasing the symptoms?
What were you doing?
What were you doing at the time that it started? Good one. Can't hear you. What alleviates it? I'm sorry? Yeah, is it radiating anywhere? Okay. Has it ever, good question, has it ever happened before? Yeah, has he taken anything for it? Those are all very good questions. And he's going to tell you it hasn't happened before. It is a sudden onset. Nothing seems to be alleviating it, but then nothing seems to be exacerbating it either. He's not taking anything at all. He's not on any medications. He's not taking any kind of medications. He just all of a sudden had this chest pain and this shortness of breath. Any other questions? That's an excellent question. Does the pain increase when he takes a deep breath? And he's going to tell you yes. Now, what does that tell you? That it's more likely respiratory than cardiac, doesn't it? It's more likely respiratory than cardiac. And so that's going to lead our decision. You said you're going to do cardiovascular respiratory assessment. Now you would be telling me I'm going to do a respiratory and cardiovascular assessment, wouldn't you? So we're going to flip-flop these just based on that one little history, that it increases worse when he takes, the pain increases worse when he takes a deep breath. There's another question you haven't really asked him that you probably should. You've asked all around it, but you haven't gotten to it. What does it feel like? It's sharp? That's not the one.
Does it hurt when you press on it?
Does it hurt? The one I was looking for is where is it? You know, he said chest pain, but you haven't asked where on the chest it hurts. And he's going to press on the upper part of his chest. It's hurting in this area. So this again also tells us probably not cardiac, is it? More likely it's going to be respiratory in nature. So those are really good questions to ask him. Now then, let's go to the respiratory assessment we're going to make, and let's talk about inspection. Let's look at what we're going to assess just from looking at him. What kinds of things are you going to be looking for?
Use of accessory muscles.
Is he using any accessory muscles, and how do we know that?
Nasal flaring.
Nasal flaring and chest retraction. So we need to get his shirt off, don't we? We need to look at his chest wall. Also, what else is we're looking at that chest wall are we looking for? Equal expansion of those lungs, exactly. So as we're looking at him, we're looking for that accessory muscle use. We're looking at the expansion of his lungs. Is he equally expanding both sides of his lungs? Be very important in this patient. One of the things I would immediately do is be looking at his face. And what am I looking for?
Cyanotic.
No, not cyanosis. Cyanosis is such a late sign of anything that I'm going to slap myself upside the head if I waited to wait for cyanosis to my patient's in trouble. I'm going to look for diaphoresis, and I'm also going to look for one more thing, just looking at his face. Not so much as coloring, although that could be part of it. I'm looking for that signs of distress, that feeling of impending doom. I'm looking for that anxiety. You can see that on their face. They come in with a sign of distress if they're in distress. You can see that on them. You can touch them and see if they're wet. You know, one of the first things I do with a patient that comes in that I suspect might have any kind of distress is just touch them and look at their face and see what they look like. Are they looking distressed? Are they diaphoretic? Because if those patients, whatever's going on has gotten to the point of a distressed look and diaphoresis, it's probably pretty bad. And I need to really kind of pick up my game and see what's going on. You know, if they're kind of sitting there eating the potato chips and complaining about this, then I'm probably okay to do a more thorough assessment, right? A more thorough history. So you have to take these little cues and use them as you can. This patient is going to look distressed. He's going to look distressed. In fact, his coloring is not good. It's not horrible, it's not cyanotic, it's not, oh my God, where's all his blood? But it isn't going to look good. It's going to look pale and anxious and diaphoretic. He's going to have that look to him. So in inspection, I'm going to look for those things. I'm not really noting at this point that there's any unilateral chest expansion issues, but he is obviously struggling to get his breath in. There is no chest retraction. Adults don't do that a whole lot. So you got to be pretty darn ill before you really see chest retractions. And if we saw that, we would certainly think more about things like asthma, wouldn't we? If we saw those retractions. But he does look pale. He does look anxious. He is diaphoretic, and he definitely has labored respirations. So that would be something I would look at as inspection is concerned with the respiratory system. Now that we can auscultate, then we're going to auscultate those breath sounds. We are going to hear diminished breath sounds in the right lung, upper, lower, all around that lung we have some diminished breath sound. But the left lung is clear. So what does that tell me? Maybe a pneumothorax? Could be. Absolutely could be. Are we going to need to percuss? Let's palpate first. Are we going to palpate?
Yeah.
Yes, and what are we palpating to find? We might be palpating to see if there's symmetrical expansion. What else? What else do we palpate for? Could be tactile fremitus. And if we found tactile fremitus, that would tell us what? It tells us consolidation. And where does consolidation live inside that lung? In the alveoli. So now we're looking at more like things like pneumonias rather than pneumothoraxes. So what's another reason to palpate? Subcutaneous emphysema. We always palpate for tenderness. One of the things you palpate for is tenderness. And as you palpate his chest, you're going to find that right upper lobe is tender. Is tender. Now we typically do not percuss tenderness, but we might percuss the lung to see if there's any kind of consolidation in there. It was not done, but had it been done, they might have heard the consolidation of the fluid that's in the lower part of the lung. But they didn't. They didn't do that. Instead, the patient went for a chest x-ray, and it showed a pneumothorax with an air fluid level and a collapsed lung on the right side. So that's what they did. Saw this patient in distress, went ahead and sent the patient on for an x-ray, did find the pneumothorax, and there's some air fluid in there, and the lung is collapsing on the right side. So what do we expect will happen at this point? They're going to put some chest tube in. Do you know where they're going to put this chest tube in? Upper right? Nobody agree with that?
It's air.
To get the air out, they're going to put it in the upper right. What about the fluid? And the lower right. Yeah, they inserted two chest tubes, one in the second intercostal space and the second in the eighth intercostal space. And why was that? They wanted to remove that air, and they also wanted to remove the fluid that was in that lump. The second chest tube immediately drains 1,200 milliliters of blood. What critical concern do you have for this client? Hypovolemia, and that can cause what? Yes, that can cause hypovolemic shock. So now noting that you're standing there at the bedside, they've put this chest tube in and all this blood has come out of that chest tube, you immediately have to start thinking, my patient could easily go into shock. So what interventions are you going to do for this patient? We're going to give fluid. What fluid do you expect to give first? Normal saline at what rate? We're going to give it wide open, aren't we? We're going to give them a nice bolus of this normal saline. What else are we going to do for this patient? That normal saline isn't going to be enough, people. Type and cross-match for blood. What else? What's the question? I still don't understand you.
Medications that can constrict vessels.
Not yet. He's wanting to give medications to constrict the vessels. Got a lot of other things you ought to be doing for this patient. You're going to put them on close observation vital signs. What else? Yeah, we've got the HDH crossmatch already done. We've already ordered it. It's not completed, but we've ordered that. Now what else?
Oxygen.
Yes, we're definitely going to put oxygen on them. Tell me how much. A non-rebreather mask or a partial rebreather mask. When you put that partial rebreather mask on, some hospitals won't let you use a non-rebreather. You put that partial rebreather mask on, tell me the procedure for doing that.
You're going to inflate the bag.
We need to inflate the bag. So how do we get that to happen? Anybody in here 24 years old? No? Anybody close? Is your life valuable?
Yeah.
Why? Can you justify why you're valuable?
Because I haven't lived enough.
Yeah.
I haven't lived long enough.
You haven't lived long enough? Just what have you contributed in the 24 years you've been here? Why is a 24-year-old's life valuable?
They have a whole life to live.
They have a whole life to live, and what else? There are probably people who are very invested in them. There are probably people who are very invested in keeping these people alive. They would really like it if you would be as invested in keeping them alive. This is a very valuable patient. So sitting there looking like you have got clue what to do is not helping this patient. Now then, the question on the table is we're putting this non-rebreather mask on. Actually, we're going to put a partial rebreather mask on. Could you please tell me how to do it? All right, so how much oxygen are you putting on it? Bunch, aren't you? Yeah, you're going to turn that thing up about 10 liters or higher. Yeah, we're going to turn that knob up so that that bag inflates, doesn't it? And we're going to put that face mask on that patient. So now this patient's laying on this stretcher. It's got the oxygen on. has IVs infusing. What kind of anti-calf did you put in this patient to put that normal saline in? Why an 18? We think they're going to get blood, don't we? So we're going to put 18 gauge in. We've drawn the blood out for the H&H and cross-match and whatever lab tests you think they might want. We've done that. We're running normal saline in. Do you have this patient just laying flat on their back? Where are they laying? We're elevating them probably as much as we can, right? Whatever they can tolerate, we're going to do this. Patient may have some air hunger, not even let you lay him back. Anything else we ought to do for this patient prior to going about our business and getting further orders and that sort of thing? We've got him on close observation, vital signs. We need to keep him warm. We need to keep him warm. We're putting a lot of cold saline in that patient, so you need to find a way to keep that body warm, because if he starts to chill, that takes energy, doesn't it? And this patient is, we're very concerned, could end up in shock. We don't want the patient to become shocky and then say, oh, I know what shock is, I'll treat that. You want the patient to prevent going into shock. This patient's 24 years old. Somebody probably cares about this person. I know there's a lot of times you wonder why, but people do care about 24-year-olds. So we want to keep this patient warm, oxygenated, volume, close observation, and then we'll go in to see what kind of orders that they're going to give us on this patient. They take the patient to surgery and they discover a bullous lesion in the right upper lobe that's actively bleeding with a small blood vessel overlying the lesion and a small squirting vessel on the chest wall. A bulectomy was performed and bleeding vessels clipped. So when the patient came back from surgery, he essentially had, as we said, the chest tube in the higher and another chest tube in the lower. Now then, when this patient has these chest tubes in place, I want you to tell me what type of dressing you're going to ensure are on these chest tubes. This one just has skin right now, so dress it for me. What goes on first? Vaseline gauze, and where does it go? It goes around those tubings and around that skin, and just close up that little entry as best as possible. That's the first thing that goes on there. Then what goes on there? I have 4x4s, and particularly a 4x4 that has been split. And so you'll put a 4x4 that's been split on both sides so it wraps nicely, lays flatly around this tube. A fenestrated 4x4, or they may call it a drain sponge. They've called all of those things. But they're just a 4x4 that's partially split and it wraps around that tubing. And then what? What kind of tape? I'm sorry? Yes, and that's because it'll be occlusive. They may even put like an ABD bat or something, and then that very occlusive tape. It could be the transparent films, but it just needs something occlusive that's over it. A lot of times they put that very, what looks like kind of a graphic type of paper. It's got a mesh to it, and they'll put that on top. Doesn't matter, it just needs to be occlusive. Now then, we're taking care of this patient who has this chest tubes in place. What types of assessments are we going to do on this patient when we go into the room? I'm sorry? We're going to look at things like the evaluation. Let's start with the patient, work our way down. We're going to look at his breathing effort. We're going to look at the rate, the depth, the effort of his breathing. We're going to go back and look for that bilateral chest wall expansion. We're going to look and see what his trachea is doing, aren't we? Because if that lung completely collapsed, that trachea may shift over to the opposite side, huh? That lung, the other pressure may pull it into the opposite side of the body. So we're gonna definitely look at that. We're gonna look at all the things we looked at before as far as, you know, does he look anxious? Does he look like he's in any distress? We're gonna look at those sort of things at his chest wall. We're gonna look at his dressing to see if it's dry and intact. And we're gonna palpate for subcutaneous emphysema. And where are we going to start when we start palpating this subcutaneous emphysema? As close to the chest as you can. Now we've got a dressing over this, so most likely we'll have to come to the edge of the dressing, and we will go all the way around that edge of the dressing and out just a little bit to see if there's any subcutaneous, because what causes subcutaneous emphysema? Air leaking under the skin, right? It's air leaking under the skin, so we're gonna feel as close to this tubing as we can around that dressing and just note if there's any air leaking under that skin. Exactly, with our fingertips. We'll look for things like how tender is it. We're also be very interested, is he taking deep breaths? Because if he's not, he could develop atelectasis, couldn't he? And if he develops atelectasis, then those alveoli can fill up with fluid, and eventually we can even get pneumonia. Last thing we need with our patient who has a low hemoglobin level because of that blood loss is the development of a pneumonia as well, right? That would be a horrible thing to happen to this patient. So we're gonna make sure that they're doing pulmonary hygiene with this patient to keep them breathing deeply even if it hurts. And if it does hurt, we'll have to give him something for that, won't we? So that he will breathe deeply and not develop any atelectasis. If he develops atelectasis, how are we gonna know it? What's the signs and symptoms of it? A low-grade fever, what does that mean? Will it be 102? It could be. It definitely could be. Probably not much higher than that, but yeah, you could get 102. But most of the time it's in the 101 range, somewhere between 101 and 102 in most cases. But it could be 102. And then what else will be our signs and symptoms? Well, he's already going to have shortness of breath. That's not going to help us. Yeah, diminished breath sounds in even areas that he doesn't have a collapsed lung, right? We're going to be listening to these different lobes, listening for those alveoli breath sounds and see if they're fully inflating by listening at the lowest point. So even on this lung, we might hear it with atelectasis. So we're going to listen for that. We're certainly going to be looking for fever. And we have to keep in mind, if he's developing an infection with his chest tube, he may also run fever with that as well, might he? So it'd be very good if we prevented atelectasis so that we're not trying to differentiate between atelectasis and an infection from the chest tube. So it'd be a very good thing, and the way we prevent atelectasis is extremely well done pulmonary hygiene. So that's what we're going to do with that. We're going to change those dressings at whatever has been prescribed to change them. And when we change those dressings, we'll look for things like insertion site inflammation that might indicate any kind of infection. Also, if there's an infection there, we'll look at that drainage and see if it shows cloudiness. That would be a sign of infection, wouldn't it? Whereas the drainage normally is either going to be just air, or it's going to be serosanguinous fluid, or it's going to be bloody type of fluid. So we would look for any kind of changes to that drainage. And the longer this patient has this there, now remember they clamped those vessels that were bleeding. So we would expect this to become more serosanguinous type rather than bloody as it was initially. So if we were to see serosanguinous change to bloodiness, then we would know what? You're watching this over time, and you note the patient that's had serosanguinous drainage out of this chest tube all of a sudden has bloody drainage out. What does that tell me? He's got more internal bleeding. Some other vessel is bleeding, and that would be a very bad thing. That would be a medical emergency when we need to call the doctor about that. So these are the things that we're going to look at him from his standpoint in this part. Now, he's going to have these chest tubes connected to closed drainage systems, isn't he? He's going to have them connected to closed drainage systems. And I'm going to use this diagram of a 3-bottle system. Before we had the fancy Dan thoracials and pleurovacs that we have now, and actually this is well before my time, we used to use 3 bottles as our closed drainage system. And I like to always use these to kind of explain what those pleurovacs and thoracials do. At United Regional, have y'all seen chest tubes that are there for pneumothorax or hemothoraxis? Which system are they using? Is it a pleurovac? Is it thoracial? A thoracial? Is it dry or is it a wet one? Do you add water to the suction device? You do add water to the suction, so it's a wet one. So as we look at this, in those thoracials, in those pleurovacs, they are designed around a 3-bottle system, which means we have a bottle for the collection of the air or the blood or the serosanguinous fluid or whatever's coming out. We have a bottle for that. We have a bottle that's called the water seal, and then we have a bottle for applying suction to that chest tube. Now then, all this does is collect, and what this does is put a little gentle pressure on that system to kind of inflate that lung a little faster and to drain things out a little faster. It is not essential to have a suction. Really, it really works better on drainage than anything else, and it's not really essential. You don't actually have to have suction on these chest tubes. You can just use a water seal. This is the most essential part of a water seal. This is by far the most of the chest tube drainage device. Most important part. In fact, it is possible to just have a one bottle system. Certainly you can have a 2-bottle system. This is absolutely not necessary. It is a nicety. But what the water seal does is it submerges that chest tube, it's hooked to the tube, submerges that chest tube down below water level. And that seals the chest wall so that atmospheric air is not getting into the lung cavity, into that chest wall thorax cavity. You don't want any atmospheric air into that, because the way that this lung is going to reinflate is by negative pressure, pulling back, not pushing in, which is positive pressure. So you absolutely have to have the water seal. It's the most important part of the system. And you need to have some water in that water seal. It'll be filled up to a certain line on your device, and that water needs to be there. Otherwise, you have not created a water seal. When we first put the chest tubes in, the bubbles, the air that's in that chest cavity will bubble out of there. After these tubes have been in here for a few hours, that bubbling should get less and less and stop in the water seal. It should stop. Bubbling in the water seal after a few hours of insertion indicates an air leak. So it should stop. As far as the suction device is concerned, the doctor will prescribe how much suction he wants. It's usually 20 centimeters. And all you do is fill the line up to the mark that says 20 centimeters with water and put this on the suction. And once you turn the suction on, it kind of bubbles a little bit. And when that happens, you know you've got 20 centimeters. It's the water level that puts the pressure on, not the suction device itself. And that prevents you from over-pressurizing those lungs. So this is kind of what's in those pleurovacs thoracials. Now they may look more like something like this. And you're going to have an area that you fill the suction container with. This one looks like it's probably more of a dry system. A dry system, the suction container, you don't keep filling it and you look at a little indicator that tells you that you've got the right amount of suction on it. Some hospitals use those, some hospitals use the wet ones where you can actually see the fluid level and see it bubbling, but this is the suction. And then we have to have a water seal chamber. And again, that water seal has to be below water, or you do not have a water seal. And then you have the collection device. And a lot of today's models, this collection device can be removed. It can just be popped on and a new one put in without changing the whole system. Is that the way it is at United Regional? So in my experience, when I worked there, that was how it was. And so if you were to fill this thing up, remember our patient had, 1,200 milliliters immediately. So he only had this much room left in his device. And so once that got to the 2,000 mark, we would need to change this collection device. And it would be nice if we didn't have to change the whole thing. And a lot of the systems now, you don't have to do that. So I suspect that's what's happening. You also have some sort of kickstand on here to keep this thing standing up. So it's essential that you get the water in the water seal, and there'll be a mark, how much water to put in there. It's essential that you put the water to the mark on the suction control chamber, and then you hook the chest tube to this device, and if suction's ordered, then you hook suction to the device. When you turn the suction on, you just want the suction control chamber to bubble a little bit, or if it's a dry system, there'll be a little indicator area on there to tell you whether it's good or bad. And then you monitor this chamber. Every time you come in the room, you monitor this chamber. And what you're looking for is to see when the patient breathes, does the fluid level go up? And when they exhale, does the fluid level go down? And what do we call that? Tidling. That fluctuation is called tidling. And what does tidling indicate? It's working properly. That's what it indicates, that it is working properly, that we're happy with that. So what if we went in and the tidling was not there? What would that tell us? It might tell us that it's just done, it's inflated and everything's good. But it could tell us some other things are going on. For example, there might be a clot that's preventing that from fluctuating. So we would need to look for something like that. Or it could be that there's an air leak, or perhaps a connector is not working. And the way we oftentimes look for those things is as we're looking in this water seal chamber, we look for bubbling. Bubbling tells us air leak. Bubbling in that water seal chamber tells me air leak. And when I see an air leak, what I think is an air leak with this patient, I start connecting, making sure those connectors are all well connected all the way up to my patient. And then if that all seems to be good, I put my hand around that opening and hold it real tight and see if that stops the air leak. Because if it does, it tells me that the air leak's on the other side of my hand. Some of these newer devices even have an air leak monitor on them, like this one does. And it's not a great picture of it, but it's kind of cool because it'll have like a 1 to 5 scale. And as those bubbles start to move towards the side, it tells me how bad the air leak is. So if the bubbles are only staying in the 1 scale, then that's not a very bad air leak. If they're over here in the 4, then that's a bad air leak. They get the 5, that's a really bad air leak. So that's kind of a cool thing with this air leak monitor, is that they tell us on there just how bad our air leaks might be. But you look for air leaks in the water seal chamber. Now then, our patient had 1,200 milliliters out immediately, and we're about to send them to surgery. So we're about to send this guy from surgery. What would we do with that 1,200 milliliters that's in this? Mark it. We would mark it right here and put the date and time, wouldn't we? Now the patient comes back from surgery and it's here. We would say since surgery they had how much drainage? 200 milliliters, so we would mark that again, right? So ever so often, depending on the policy, at least every shift, we would go and mark where the level is, and then count back from the last time it was marked as to how much fluid output there's been, right? Everybody understand that part? What are we marking it with? A Sharpie. We're marking with Sharpie and putting the date and time on that. And that's how we'll do the intake and the output. That's how we'll do the output on this device. And then when it's full, we'll just transfer it out. Now, when we document all this, we're also going to document the color, the characteristic, not just the amount, right? We're going to talk about what it looks like and if there's any changes in that. Now, the patient needs to ambulate. Remember, atelectasis is a huge concern for this patient, isn't it? So this patient needs to ambulate. We can ambulate this patient. We've just got to take these devices with us. We need to keep them below the site of insertion. We can take the suction off. We can take the whole suction off of that and walk them around. Because what's essential is the water seal. Everybody understand this? Okay, so we're taking care of this patient, and we walk into the patient's room, and we note that this device has dislodged from the chest tube coming out of this patient. What should we do first?
Stick in place. And drop.
The chest tube's in place, but the device is no longer hooked to it.
Sticking it to the jar.
Stick it in a bucket of sterile water. So one of the things that we're going to need in this patient's room is a bottle of sterile water, right? An unopened bottle of sterile water. Doesn't have to be a big one, it can be a small one. And then if we were to come in and the chest tube device is dumped over and it's no longer connected to our patient's chest tube, we can stick the end of that chest tube into that sterile water. And then we can go ahead and set up another one of these, a clean one, and hook it in place, call the doctor, get the chest x-ray, right? That's what we would need to do. So we would immediately put the end of this into the sterile water that we kept at the patient's bedside for this purpose, an open bottle of sterile water. And that reseals the water seal, gives us some time to make up a new one of these, hook it to the patient, call the doctor, do the chest x-ray to see if there was any damage that occurred. That's what we want to do, right? What if we walk into the patient's room and the chest tube is laying on the floor? We're going to cover the hole with what? We're going to cover the hole with an occlusive dressing. So what's the first thing we're going to put over that hole? Vaseline gauze. So another thing we want to have in this patient's room is a fresh dressing set, don't we? So we're going to put that Vaseline gauze on there, the regular gauze, the ABD, and the occlusive tape. So we want the dressing materials in the room at all times, because if that comes out, we want to be able to change that dressing immediately. Then we call the doctor, get the chest x-ray, and they would determine whether or not they need to put the chest tube back in. Everybody understand these concepts? So the client's prescribed 4 liters of packed red blood cells. So what are our nursing responsibilities in order? So what's the very first thing we read on the chart? Transfuse 4 liters of packed red blood cells. What's the first thing we're going to do? Huh? Get a consent form? Okay. Remember, we've already typed and cross-matched, right? So we don't have to do that part. But if we would have to type and cross-match this patient too. But we're going to get a consent form. So we're going to go into the patient's room and we're going to get them to sign consent to transfuse this blood. And he's 24, so he can sign his own consent form. So what goes on that consent form? Nothing? The risk involved with that. Exactly. So there are certain risks, and they're all about bloodborne pathogens, aren't they? And fluid overload, those types of things are our risks. So we're gonna put those risks on there, and this patient's gonna read that and then decide if they want to have this blood transfusion. While we're there getting the informed consent, what should we be asking this patient? Like, have you ever had a transfusion reaction? First, let's ask if he's ever had a transfusion. If so, how many? And second is, have you ever had a transfusion reaction, and why do we care? We're worried about multiple transfusions and the passing of antibodies, or the development of antibodies to antigens that the patient has received from the previous blood. So the patient's going to receive, if they've received multiple units of blood, then they receive antigens in that blood, and then they develop some antibodies. And so we could get some antigen antibody types of reactions going on, couldn't we? So we're going to ask that question. Have you ever had transfusions? And if so, did you have a transfusion reaction? And if he says yes and yes, then we say, what happened? This kid has never had any transfusions, so we don't have anything to go on previously, do we? We just have that, we're gonna start this on him today. Okay, so we've got the consent form signed. What are we going to do next? I'd probably check the patency of that ID before I did that. So I would look at while I'm in there getting that consent form, I'm gonna make sure that ID is good. Gonna make sure that ID is good because I'm gonna use it. If it's infiltrated, I don't wanna have the blood setting out on the desk while I go and try to start an IV on this person. So I'm gonna check, make sure that that IV side is patent and usable for this transfusion. There's another thing I'm gonna do before I go get the blood. What is it? Take a set of vital signs, and we're gonna consider those our baselines, aren't we? We're gonna consider those our baselines. So now we go and we get the blood, we bring it back to the unit, what are we gonna do? We're gonna check it with another nurse, and what are we checking? Patient name, medical record number, the blood type on the type and cross match, as well as the blood type on the blood bag, right? We're gonna make sure whatever they said the patient was on the type and cross match is exactly what it says on the bag of blood, not only the ABO group, but the RH factor as well, right? And we would question if those things were not the same. What else are we gonna check on that blood bag? The expiration date. And then we're gonna look at that blood, and we're gonna make sure it looks blood color, and that it's not brown or bubbly, or anything that would indicate there was some contamination to it. We're too separated, you kind of gently do this, and if it should look like blood. It should look like you stuck your finger and you filled up a bag of blood. It shouldn't be all separated and have any lumps in it or any discolorization or bubbles or anything like that. So we're gonna look at that blood very carefully to make sure that it is appropriate. When we take that blood into the room, what else are we going to take with us? Tubing. And what makes blood tubing for packed red blood cells? Blood tubing. It has a filter, a specific type of filter on it, and if it's for packed red blood cells, what else does it have? Normal saline. How big a bag? Not a liter. With 4 liters, maybe, but usually it's 250. Usually it's a 250 milliliter bag in this wide blood tubing is what we hook. You could do a 500, but usually it's 250. Also, what other thing are we going to take into this room? Do one more thing. I'm sorry?
Like if we had a antibiotic.
So what are you going to take? Epinephrine? No. You could. You can have the crash card available if you want to. You'll have epinephrine on it. Something else though. Nobody giving blood? Nobody with the nurses giving blood or not giving blood in United Regional?
Maybe another nurse to witness it to the doctor.
Huh?
Maybe another nurse to read.
No, you've already done that at the nurse's station. Y'all aren't going into these rooms? You're allowed to go to the rooms. You're allowed to watch, you're allowed to ask questions, and you're allowed to learn. But y'all aren't doing that? It's too bad.
They can't
You
win.
know how anybody give blood? That's because y'all choose patients that are being discharged that day, I've noticed.
I saw a kid win.
All of your patients have been discharged the day you took care of them. I've been really impressed with that. Yeah. Y'all want to challenge yourselves. That's okay, my test will.
I guess it's a thermometer.
A warmer?
Blood warmer only if prescribed.
The blood pressure.
Not Benadryl, no. You're gonna take another bag of saline and tubing, why? If they have a reaction, you're going to start a rapid infusion of saline. You don't want to use the saline that's connected to the blood tubing. So you're gonna take another bag of saline and tubing just in case you need it. You're gonna keep that at the bedside. All right, so now you're in the patient's room. You've got the blood that's been double checked with the other nurse. You've got your vital sign equipment should be in the room already from when you took it the first time around. And so now you're ready to start this blood. What are you going to do? Well, you haven't got time to stay with them yet. You haven't got it even up. So what are you going to do? You're going to prime the tubing, hook this to the patient, and start what first? You're going to start the saline. You're going to start the saline, and then when you're ready to start the blood, you're going to stop the saline and start the blood. How fast are you going to run that blood? You're in there making decisions, guys. How fast are you starting that blood? 70 milliliters per hour? 75 milliliters per hour? Why 75? In the first 15 minutes, we want the patient to have how much? Man, I wish those computers could be used for good rather than evil. In the first 15 minutes, we want that patient to receive how much blood? $50 milliliters. 50 milliliters. So we're going to have to do 50 milliliters in the first 15 minutes, but a pump runs per hour. $200 milliliters per hour. We'll put 50 milliliters in within 15 minutes. Yep. Then we decide that we're going to stay with that patient. As we're staying with that patient, why are we staying here? We're going to look for a reaction. How are we going to know our patient's having a reaction? They're what? They'll have pain.
Flushing,
Flushing,
rain,
sweating, diaphoresis,
itching.
itching. That's it. Elevated temperature. That's it.
Difficulty breathing.
Difficulty breathing. Okay. So this little thing came from the memory notebook, some things to think about as far as blood transfusions are concerned. And let's see how many we did. We determined the patient's allergies. We really talked about that, but we would. Previous transfusions to reactions. What allergy are we most concerned about? We're giving a transfusion. This is what I like. Y'all be giving this transfusion. You'd ask the patient, are you allergic to anything? And they might tell you what they are allergic to that means you can't give this blood and you won't know what that is, and so you'll just give the blood anyway. No, not the tubing. Good guess, though, I appreciate that. Citrate. This blood is oftentimes preserved in citrate, and many people are allergic to it. So that anaphylactic reaction that y'all are so concerned about would be most likely to citrate. Would be a good thing to know. When were y'all planning on learning this? What if I had not brought this in today? When were y'all planning on learning it? Got an answer? Were you not planning on learning it? You're not gonna work in the areas where they give blood transfusions? You told me the last time we were together you were gonna work med-surg, ICU, ER, labor and delivery. Are those not areas that give blood transfusions? Yes. Were you not planning on doing it? I want an answer. When were you planning on learning this?
Yeah.
When? In training? Y'all they're gonna teach you everything that you needed to know about nursing in the weeks that y'all are in training that you didn't learn the 2.5 years you were here. Now let me ask you this. You're in training. You're in training. Who are you in training with? Each other? Preceptors, that is just you and a preceptor? What kind of training are you getting? Are you doing a residency, an internship, a preceptorship? What are you doing? Internships. So internships usually about 3 months long. What do they consist of? Classroom time, preceptorship time, right? So who are you in training with in those classrooms? Is it just you and the teacher? New nurses. New nurses. Let's think these new nurses might not come from a Western State University. How are you going to feel if they know this and you don't? You going to feel pretty special? In a bad way. In a bad way. Also, let's say you're working with your preceptor and you go into the room and you're going to do these blood transfusions and you've got the knowledge level most of you currently have right now. What's that preceptor going to think about you? Not safe. They're going to say to you, what did they teach you in school? Are you going to say back to them, I thought I would just wait until I got in training to learn this stuff? What are you going to say? Because that's what you just told me. So what are you going to say?
I skipped that class.
What did you say?
I skipped that class.
I skipped that class. Unfortunately for some of you, every answer is going to be, oh, I skipped that class too. And they're going to say, did you ever show up for school? Guys, they are not going to be warm, friendly, and want to teach you all this stuff. What are they teaching you in those internships? How their hospital does it, and things that they feel like would not be in a normal BSN program. For example, how to work those ventilators. They expect you're going to come out with some idea of what a ventilator does, but not how to work them. They're going to expect that you're going to come and understand something a little bit about hemodynamic monitoring, but not how to use the Swan-Ganz that are pulmonary artery catheter. That's the kind of thing they're going to teach you. They're going to teach you, they're going to expect that you've seen a delivery and you kind of know the process of it, but not that you've really checked for cervical dilation and know how to intervene in all of the different stages that occur. They're going to expect you to have some concept of all of these things, but certainly not to the depth that your specialty will require. But they are certainly going to expect you to have what is considered basic knowledge from a baccalaureate program. This is basic knowledge from an associate degree program. This is stuff they'll test on the in-class. This could be in an associate degree, could be in a diploma program would teach you this sort of stuff. And you're going to be sitting there next to new graduates from those programs or from other BSN programs going, well, I didn't learn that because I thought you would teach it to me in training. Is it going to make you feel good?
No.
It's not gonna make me feel good when they call me. It's not gonna make me feel good at all, because they will call me. And they will say, why doesn't your student know? Or your graduate know? And I'm going to say, I don't know, but I assure you, I tried to teach it to them, but you ought to see what bunch of deadheads they were in class. You think that happens? Yep, happened just a couple of weeks ago. Got us graduates from last class that is working at Parkland in the emergency department, and I got the call from the educator. Your graduate is the only one who did not know. They did not know they were trying to infuse a medication that was going by bolus by gravity, and they did not know how to do it. Everybody else knew how to do it. She also did not know how to do an assessment on a client that was a new admit to that emergency department. She just kind of walked in and just looked at them like, I don't even know where to start on this. She also did not know what to do with the data once it was assessed. Once you assess, put your stethoscope there and listen, and then put it over here and listen. And once she got the abnormal data, she didn't know what it meant. So they were not pleased. I was not surprised because I've seen you guys doing this semester after semester after semester. Not all of you. Not all of you. Some of you seem to get it and know what to do with it and want to use it. But a lot of you have no idea of these concepts. And these are considered fundamental concepts in any nursing program that is going to end up with an RN at the end of the title. So you might need to think about that. These wonderful, warm, loving nurses that are going to take you under their wing as preceptors are not going to be so warm and loving, let me tell you. Let me tell you. They're going to ridicule you. They're going to tell everybody they know how crappy you are, how crappy the program is. They're not going to want to deal with you, so they're going to give you the crappy assignments that don't take very much supervision. They're going to complain about you to their managers and hope that you get moved or fired. Unless you are energetic and interested in learning. And that's not what I'm seeing among many of you. So just be aware of that situation. It's going to happen, seen it too many times. I know you're thinking not you, but just wait. And then you can email me. Y'all remember my email so that when these nurses treat you like that, you can email me and tell me, because it'll happen. Got too many emails I could read now about that. Okay, so allergies, it's just citrate. We've already asked about the previous transfusions. One of the things we have to do is we have to administer this blood within 30 minutes of receiving it from the blood bank. Why is that? Yeah, the cells will start to lysis, and you'll also see some bacteria grow. So if you don't get it started within that 30 minutes, you cannot take it back to the blood bank. So that's why it's important to do things like a set of vital signs and make sure your IV's infusing beautifully before you do that. Never add any medications to blood products. Some key points: verify patient's ID. We know that 2 patient identifiers, those are room number, patient name and medical record number. Check the doctor's order, check labels on the blood bag and blood bank, we talked about that. Baseline vital signs, 18 gauge or 20 gauge needle. The 20 gauge is usually for children, but some of these 20 gauges are what they call thin wall angiocaths. They're going to have a pretty much the same diameter as a regular 18 gauge. So if you've got thin walled angiocaths, then that would probably work as well. Normal saline, blood transfusion administrations that we talked about that. Blood tubing should be changed after 4 hours. We didn't talk about that. Also, we're going to infuse each unit over 2 to 4 hours. Now let's go back to our patient. We have 4 liters that we've got to get into this patient. So this first liter, we're going to put in how fast? 4 hours? Well, we don't want to go over, so I'd probably try to aim for 3. That way, if anything happens, I've still got another hour. So I'm gonna try to aim for 3 hours in that first bag of fluid. Now then, we're gonna hang the second bag. Some institutions will let you run 2 bags of packed red blood cells through one tubing. However, remember, after 4 hours. So if you run this thing in over 2 hours, then you could probably run the second bag in the same tubing over another 2 hours. With this patient, would I do that? No, why not? Very strong reason, why not? Yes,
A unit of blood is like only 250 mils, right?
about 300,
So she's getting 4 liters.
yes. Yes, what they call a liter of blood, which is just a bag,
Oh,
but it's about 300.
okay.
They'll call it a liter, but it's not. It's about 300 mils. So what are we gonna do then? Why not give all 4 bags of that fluid 2 hours at a time? Very good reason for this patient. Think about it.
What specialty?
You've got 4 bags of fluid. You've got 4 bags of fluid you've got to give this patient over time. I'm telling you to run it in like 3, closer to 4 hours each bag. Why not do it at 2? That's safe for most patients. Why not do it at 2? If you did each bag in 2 hours, you'd only have to change the tubing 1 time. If you do each bag over 3 hours, you've got to change the tubing after each bag. So why not do each bag over 2 hours? You don't want to send him into fluid volume overload. Bing, 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 bing. And that's what could happen with this guy. You're giving him 4 bags of fluid, they're about 300 milliliters a bag. You're giving him 4 of them. So you're going to run this bag in. You're going to run this bag in over about 3 hours, maybe up to 4. You're going to run this bag in. You're going to assess for fluid volume overload. Then you're going to go back and you're going to change the tubing, hang the next bag. After that one, you're going to assess for fluid volume overload, and so forth and so forth. Now, what would fluid volume overload look like? Crackles in the lungs, distended veins, increased shortness of breath, those kinds of things. So we're going to look for those things. If they happen, what are we going to do? We're going to call the doctor and what we're hoping for. A diuretic, loop diuretic. So they're going to run this one a little slower. We think his bleeding stopped, right? They clamped those vessels. So we don't think we have to run this one in so fast. We think his bleeding has stopped. We're just replacing that blood volume. So we're going to run this on a little bit slower so that we don't put him in fluid volume overload. We're going to try to get all 4 of those liters in without doing that. We talked about this, checking this with 2 nurses. We talked about all of that. We talked about not warming unless there's a risk of hypothermic response. The doctor will order the warm blood if that's what he wants, and then you'll use blood warming equipment for that, if that's what you're going to do. Okay. It says here baseline vital signs, then per policy. So once I start this blood, I've taken a baseline vital sign. I'm going to take my first set of vital signs after that when? At 15 minutes, because I'm looking for those reactions. And then how often thereafter? Depends on the agency. It could be 30 minutes, it could be every hour. It could be 30 minutes, it could be every hour. You'll also then take it an hour after the transfusion. Now, if you start another bag, you got to go back to the 15-minute thing, don't you? Because each bag, you're going to do that 15 minutes. Perfect. So 1 hour into the transfusion, the client's vital signs change from normal to this. So what are you going to do? In order. Stop the transfusion. Hang that saline that I made you take in there with the new tubing, right? We're going to disconnect the blood tubing And we're gonna put fresh saline, fresh tubing, just regular tubing and regular saline. And we're going to infuse that in at a rapid rate. And then what else are we gonna do? We're gonna notify the physician. What transfusion reaction do we think is occurring? A hemolytic? When you call the physician's gonna tell you in this case to give the patient a dose of Benadryl, 50 milligrams of Benadryl IV, and also to give the patient 650 milligrams of acetaminophen PO, and to restart the blood. Now what? I'm sorry? Tell me what you're gonna do. You call the physician, pretend like I'm the physician, and I say, give the patient 50 milligrams of Benadryl IV and 650 milligrams of acetaminophen PO, and restart the blood. Okay, what are you reassessing for? Your problem is, guys, you've got the wrong reaction. This is not indicating a hemolytic
It's a
transfusion reaction. It's indicating a non-hemolytic febrile reaction. What causes a non-hemolytic febrile reaction? Not hypersensitivity. That whole antigen antibody problem. So the treatment for that is Benadryl and acetaminophen. You restart the blood. You restart the blood. How do I know this is not a hemolytic?
Because it denies the back pain.
Doesn't have the back pain or the hematuria. Also, there's something else there that tells me it's not. Nope. That's a good guess. Great. I like people who guess. The fact that it happened an hour after the transfusion. Hemolytic and anaphylactic reactions happen usually within the first 15 minutes and within the first 50 milliliters of blood. So this tells me this is most likely a febrile non-hemolytic. It's an antigen antibody reaction. It's not very threatening. We just go ahead and give the acetaminophen and the Benadryl, and then we start the blood back up. And we usually don't have much trouble with that after that point. And they'll usually order that Benadryl and acetaminophen, on an as-needed basis. Now then, we're ready to start the second unit. And we know this patient had this reaction. What might we do to prevent this reaction from happening on the second unit? We can give the Benadryl and the acetaminophen, and there's one other thing we might do. We're going to add a certain type of filter, what's called a leukocyte pore, P-O-O-R, a leukocyte pore filter. What that does is it screens out more of the leukocytes out of those packed red blood cells, because it's the leukocytes that carry the antigens, the antibodies. So we're going to screen those out with what they call a leukocyte pore filter. You put the filter between the blood bag and the IV tubing. And it just filters those out. You're less likely to have these reactions. And we would tell the patient from this point on, tell people you've had this reaction, they'll run those through a leukocyte pore filter from this point on. The other thing they can do is change the order to washed cells, which just means they filter out the leukocytes. In this case, most likely we would just put that filter on and run the rest of this blood. So our transfusion reactions, it's not good enough to just know the signs and symptoms of a reaction. You've got to tie that reaction, signs and symptoms to the specific reaction. So if it's a febrile reaction, you have the chills, the fever, maybe a headache, flushing, tachycardia, increased anxiety, those types of things. If it's allergic, it's gonna look like an allergic reaction. You know, if it's mild, you're gonna have some hives, maybe some itching, a little facial flushing. As it gets more severe, you've got the bronchospasm, that impending death reaction, shortness of breath. And if it's a hemolytic, you have increased anxiety, low back pain. That low back pain is due to the kidneys processing those lysed cells. And you will also see those lysed cells as bloody urine. However, that's most likely going to be microscopic. You see hypotension with this patient. Tachycardia, fever and chills, chest pain, tachypnea. This one's going to look very, very dramatic. This one can look very, very dramatic. This one's not going to look near as dramatic. If we thought our patient had a hemolytic transfusion reaction, what would we do? Stop the blood, run the new saline, send the blood, the tubing, and what else to the lab? The blood, the tubing, and on the screen. A urine sample. So if we think this is hemolytic, we're going to stop the transfusion, run the saline wide open, go run the saline in. We're going to send the blood, the tubing that was on the blood, we're going to send a urine specimen to the lab because they're going to have to re-cross-match this and see if they've given us the wrong blood, because this is an indication of ABO incompatibility. So an indication of ABO incompatibility. Those blood cells are breaking down, which means they're not useful. You treat the symptoms. You're going to have a patient that could easily go into shock. So you've got to monitor their fluid and electrolyte imbalance. So it becomes a medical emergency. The same thing with an allergic reaction. With hypersensitivities, it could go into anaphylaxis and anaphylactic shock. Therefore, you could see some very severe reactions and cardiopulmonary deterioration. So that's a medical emergency. So both of those are medical emergencies, and you stop the transfusion and you start the saline wide open. We're going to give oxygen, and if this is an allergic reaction, we're going to give epinephrine, as we would for any allergic reaction. And we're going to support this patient. Put the patient on frequent vital signs. We're going to recheck and cross-match only if it's hemolytic. All of this stuff right here belongs to hemolytic. That stuff right there belongs to hemolytic. And monitor fluid balance. So this stuff right here belongs to hemolytic. Evaluate serum calcium levels. We might do with the allergic and the hemolytic. Probably not going to do it with that one. That one usually doesn't cause much trouble. These are the two that happen suddenly. Very, very severe. Okay. Client was recovered because apparently he had nurses knew how to give blood transfusions and was able to go home without chest tubes within 4 days. So I thought y'all would be happy to know that the 24-year-old survived.
We didn't kill this.
And didn't die. Any questions about these concepts?